Dr. Look, you have to unmute yourself.
Good afternoon, everyone. I'm Thomas Look, and it's my pleasure today to introduce our speaker, Dr. John Maris. Just 1 second here, I'm trying. There we go. So before I begin the introduction, I'd like to acknowledge the sponsor of today's seminar. This is the Charles I. Siegel Memorial Lecture. The seminar is funded by the Siegel family, and the Charles I. Siegel Memorial Lecture was established in 1989 by Charles and his wife, Edith Siegel. They were longtime supporters of the Jimmy Fund, Dana-Farber, and other charitable organizations in Massachusetts and Florida until their passing. Their only desire for this lecture is that it continue to educate future generations of medical professionals, and that those who attend the lecture take notes and study hard. So, and I would also like to ask at the end of the seminar, or even during the seminar, if you could please post your questions using the Q&A tab at the bottom of the screen and not on the chat tab. So our speaker, as I said today, is Dr. John Maris from Children's Hospital of Philadelphia and the University of Pennsylvania. And John completed his medical training. Well, first of all, his Bachelor's of Science at Wheeling College, but then he moved to the University of Pennsylvania School of Medicine for his medical training, and he stayed on at Children's Hospital of Philadelphia for his residency, fellowship in pediatrics, and postdoctoral fellowship in pediatric oncology. And he has developed his career there, where he is now a professor of pediatrics. And John has received numerous awards, most recently the American Association for Cancer Research Team Science Award, and also the NCI Outstanding Investigator Award. John, as many of you know, has focused his entire career on neuroblastoma, the most common solid tumor of children, non-brain tumor, solid tumor of children, and the cause of significant mortality in children to this day. It can be an extremely difficult tumor to treat. John has pursued several areas. He's an expert in the molecular genetics of neuroblastoma. He did the pioneering work on predisposition to neuroblastoma and genome-wide association studies implicating many different loci in controlling the risk of children developing this disease. And now, most recently, he's turned his interest to immunotherapeutic targeting of neuroblastoma, and that is the subject of his lecture today, entitled Immunotherapeutic Targeting of Lineage-Restricted Oncoproteins for Childhood Cancers. John.
Thanks very much, Tom. That was a very kind introduction, and I appreciate the invitation to speak to you virtually. And so I was telling Tom before, it's ironic that Scott Armstrong was at Penn today giving a seminar in person. So I'm just sorry that I'm not there with you today. So these are my disclosures. I'm going to tell you two stories today. One developed by Chris Bossi when he was a postdoc in the lab, and he continues to develop, and with a little help from me, is a recent faculty member here at CHOP. And then a second story by Mark Yarmarkovich, who did his dissertation work with me, and is currently on the job market and is actually looking very seriously at a job with you guys. Before I do that, though, I just want to give you a little bit of background. I'm a practicing pediatric oncologist, and on the one hand, we were very proud to say that 4 out of 5 children with cancer are cured, but clearly 1 out of 5 children dying is completely unacceptable. And for those of you in the field of pediatric oncology, you know this, but for others, it's often not as apparent that we've achieved the improvement in outcomes largely through the empiric mixing and matching of different chemotherapies, radiation therapies, and it's extremely toxic. So that survivors often are saddled with significant long-term comorbidities, including second malignancies, which is just a devastating thing to see. The other dirty little secret that became very apparent around the turn of the century, 20-some years ago, is that we were really stuck in many cancers, and while we made some improvement in some, others we didn't, and cure rates really sort of plateaued, and that sort of coincided with reaching the maximum tolerated doses of impaired therapy that we could give to our patients. And then finally, as these Kaplan-Meier curves show for many of the childhood cancers, that if a child suffers a relapse, it's a death sentence. And we have, until recently, very few salvage regimens that are potentially curative. So as Tom said, the lab focuses a lot on neuroblastoma, and just a couple of slides to get everyone on the same page. I'm not going to go through this diagram on the right, but this is really just to emphasize the point that we've learned a lot about the cell of origin in neuroblastoma and how neuroblasts that migrate out of the neural crest and are destined to form the autonomic nervous system, your fight or flight nervous system. What are the normal developmental transcription factors and transcriptional networks that direct this? And then what we've really been focusing on, along with Tom's lab and many others, is how this gets disrupted and how neuroblastoma cells arise. And so these cancers are truly misappropriation of normal autonomic neurodevelopmental pathways. And thus, these are truly pediatric cancers, with the average age of diagnosis being a toddler. As I've already mentioned, it's an important pediatric problem with a disproportionate amount of the morbidity and mortality. And Tom and many others in the field have figured out many of the known oncogenic drivers, MYC amplification discovered in the early 1980s. Tom originally cloned ALK and anaplastic lymphoma kinase, but this is the most common mutation in this disease, ATRX, others. But as I'll come back to in the second half of the talk, these are all in subsets of cases, 40%, 25%, but disrupted core regulatory circuits are these proteins that are really supposed to drive proliferation or stop differentiation at critical stages of neurodevelopment. These are deregulated epigenetically in all cancers, and we think are good therapeutic targets. So this slide just emphasizes the extreme phenotypic variability of the disease. On the one hand, this is a baby with the famous 4S neuroblastoma. So all of this is tumor, and this all went away in 6 months with no chemotherapy, no radiation therapy. So neuroblastomas, on the one hand, have the highest proportion of cases that will spontaneously go away without any intervention. Judah Folkman used to think this was an angiogenic phenomenon. Most of us these days think this is likely an immune editing phenomenon, and these patients, we think, hold important clues to what could be effective immunotherapies. But what we'll focus on today is the half of cases that have these huge tumors and metastatic disease, and cure rate is at best 50%. And as I already said, it comes at a cost. So this is what we do to these kids, that when they get diagnosed, they get 6 or 7 months of very intensive chemotherapy. These are at doses that are 2 to 3 times the intensity of an average prostate cancer regimen. Neuroblastoma is the only solid malignancy where there is some minor statistical advantage to transplant to myeloablative chemotherapy and stem cell rescue. So we do that 2 times to these patients. So that's very intensive, several months in the hospital. And then neuroblastoma bears the distinction of having it's the only pediatric solid cancer where there's an FDA approved immunotherapy, a monoclonal antibody that targets the cell surface ganglioside GD2. And this definitely improved outcome in patients who got to the therapy. So this is not from diagnosis, but from patients who got chemotherapy at the end while they were already in remission. But GD2 happens to be expressed on pain fibers as well. So it's a really, really rough therapy for these patients. And as I said, the last intro neuroblastoma slide is that we have made progress, right? But the problem is that these curves aren't stable. And we really have just been pushing relapse out later and later. And as I already showed, this is just a bunch of patients who were on phase 1, phase 2 trials. And you can see that those trials often fail our patients. And relapse disease is a huge unmet need. So as Tom already mentioned, we've been trying to think of immunotherapeutic approaches to this disease, especially after the credentialing of anti-GD2 therapy. But in neuroblastoma and all the childhood cancers, it's very, very clear that we can't just take what's happening in adult cancers like we do with many kinase inhibitors and repurpose them for our diseases, because childhood cancers are fundamentally different in terms of their environmental influence, which is minimal, if any, in the childhood cancers, and they thus have low mutation burdens, and thus immune checkpoint inhibitors, which have been hugely effective in many of the adult malignancies, have been completely ineffective in neuroblastoma and other childhood cancers. When thinking about the immune system, especially if you think about cellular therapies, the immune system of a child is naive, and then we beat the heck out of them, and the T cells, when you might want to harvest them, are often state. And then the targets that one might think about, and we're going to talk about 2 targets today. They're very, very different. And what we think is really important is to go after the targets that reflect the developmental origins of the cancer rather than the PMSA in prostate cancer, the things that develop the organ of origin. And I think the only thing that all of us in the immunotherapy field have is that we don't have enough targets. So a little over a decade ago, well, about a decade ago, I was speaking with my friend Crystal Makel here, and it started as sort of a comical conversation where, as Tom mentioned, I was sort of viewed myself as a geneticist, a genomicist, and really felt I knew very little, if anything, about immunology and immunotherapy. And Crystal, who is a dyed-in-the-wool immunotherapist, core immunologist, was complaining that she didn't understand all the genomic advances recently. And so